Can I have the slide, please? Good morning. Good morning. Welcome to the session on health systems resilience during COVID, organized by the European Observatory on Health Systems and Policies. My name is Anna Sagan, and I'm a research fellow at the Observatory. It is a pleasure to be here today, and especially in this all-female panel, alongside my wonderful colleagues, Erin, Erica, Gemma, and Ruth. Next slide, please. The aim of the session is to shed light on what worked best in different countries within the WHO European region in terms of health systems responding resiliently to the pandemic. We summarize our findings into 20 key strategies that you can see on this slide. Don't worry about not being able to read what's in this table. My colleagues and I will cover them during this session. If this is not enough and you are interested to read more about these strategies and our work, please look out for our forthcoming study on this topic, which is currently in production and will be online soon. Before my colleagues and I dive into these strategies, let me briefly explain what we mean by health systems resilience and how we have arrived at these strategies. Next slide, please. So resilience is commonly understood as the capacity to recover or bounce back from a shock. Application of this concept to studying health systems is quite new and typically focuses on health systems' ability to prepare for but also manage disturbances, with some definitions focusing on acute shocks such as COVID-19 in this case, and some other definitions including more chronic strains such as population aging. In terms of health systems performance, this can be understood as the ability of the health system to maintain, or if possible, even improve the performance of its core functions, which you can see in the circle on the left. In the face of a shock, in the face of a shock, the goal of that is that the core health system goals, which you can see in the circle on the right, and especially the goal of maintaining or improving health, can continue to be achieved. Next slide. Next slide. Yes, thank you. So we have arrived at these 20 strategies by analyzing national responses to COVID-19 and distilling the characteristics of these responses that were critical to maintaining performance of the core health system functions. The key source of evidence was the information collected in the COVID-19 Health Systems Response Monitor, which is a platform developed by WHO European Commission and the Observatory, which tracks policy responses to COVID-19 in the region in close to real time. The initial work has been guided by an original list of resilience-enhancing strategies developed in our policy brief on resilience, and this list was drawn from experiences of past shocks such as the financial crisis, Ebola virus, and others. And as we continued our work, we have refined this original list to distill the 20 strategies that contributed to health system resilience during the COVID pandemic. Next slide. Thank you. So we will now dive into the main part of the session. First, my colleague Erin will speak about strategies aimed at transforming delivery of health services to address COVID-19 and other needs. This covers strategies on ensuring the ability to cope with surge in demand and managing provision of services for both COVID-19 and all other patients. Erica will then speak about strategies to strengthen public health interventions. This includes strategies on implementing public health measures in response to COVID, including find, test, trace, isolate, and support systems, and COVID vaccinations. It also covers strategies to maintain regular public health services, such as vaccination and screening programs. Gemma will then speak about mobilizing and supporting the health workforce. She will cover strategies on increasing capacity to cope with surges, as well as supporting workforce in different ways. Ruth will then speak about financing COVID-19 services. She will cover strategies on ensuring sufficient funds for the health system, adjusting payment and purchasing mechanisms, and ensuring health coverage. Finally, I will speak about leading and governing the COVID response. This was essential to mobilizing all the other functions mentioned above. And at the end, we are hoping to have some time left for a discussion and answering questions. Now, Erin, the floor is yours.
Good morning, everyone. and thank you for joining our session today. My name is Erin Webb, and I am based at the Technical University of Berlin, one of the research hubs of the European Observatory on Health Systems and Policies. My presentation today will provide some strategies and examples from countries to answer the question, how did health systems transform service delivery for COVID-19 while still addressing other health needs? This question, which is also framed using the term dual delivery, proved to be one of the core challenges of delivering healthcare services during the pandemic. At various points during pandemic waves, the demand for COVID-19 services overwhelmed hospitals and other healthcare providers, and providers had to cancel non-urgent appointments or treatments as a result of preventing infection. Still, countries used a combination of strategies to manage a surge in demand due to COVID-19 while continuing to provide other necessary healthcare services. Next slide, please. So to understand how countries have responded to the COVID-19 crisis, we have to first consider the different contexts that countries started with. The two graphs on the left show the great variation in capacities. We can see in the graph on the top left that Europe has a huge variation in the number of intensive care unit beds. Ireland has only 5 beds per 100,000 population, while Germany has over 30, a 6-fold difference. The occupancy rate of bed also matters, and we can see this in the graph on the bottom left. Before COVID-19, Malta, Belgium, and Portugal had acute care bed occupancy rates of over 80%, and in Ireland, this was even above 90%. Now on the right part of the slide, we can also see that there are different approaches to service deliveries across Europe. Some countries have a high number of doctor consultations and high utilization rates. On average, someone living in the EU visits a doctor between 7 and 8 times per year. But in Cyprus and Sweden, this is 2 to 3 times per year, and in the Czech Republic, Slovak Republic, and Hungary, this is between 11 and 12 times per year. The graph also shows the number of hospital discharges per year. And again, we can see huge variation, even between closely neighboring countries. The Netherlands has relatively low discharges for its population, while Austria and Germany are among the highest in the EU. And while these high-level figures already tell us something, we also have to remember that these numbers can vary within the country. Cities are also often better served than rural areas, and one hospital may have much higher occupancy rates than another. Next slide, please. While it's important to have the starting point in mind for the context, all countries could increase the resilience of service delivery during COVID-19, and we identified 2 main ways of doing so. The first relates to capacity, and in particular, scaling up, repurposing, and redistributing capacity to cope with the sudden surge in COVID-19 demand. The second strategy relates to the approach of delivering care and the ways countries adapted or transformed service delivery by implementing alternative and flexible patient care pathways and interventions. Next slide, please. If we dive into these strategies a bit deeper, we can identify specific actions that healthcare providers took to increase the resilience of service delivery and ensure its functioning to the extent possible. First, countries scaled up capacity. They increased the number of beds, especially in the ICU setting, and used spaces in innovative ways. Some of this scaling up was built on existing emergency hospital plans to free up capacity and set up additional ICU beds within existing facilities. And in some areas, particularly at the beginning of the pandemic, facilities such as hotels, dormitories, and rehabilitation clinics, which may have been closed, were transformed into transition centers for quarantine. And a few countries created temporary hospitals in conference venues, stadiums, or fairgrounds, and some constructed field hospitals designed to accommodate less severe COVID-19 cases, although unfortunately some of these went unused. However, this creation of excess capacities needs to be considered in the context of the high levels of uncertainty during the pandemic. And let's look at a country example. So in March 2020, Portugal had fewer than 600 ICU beds, but this increased to over 1,000 beds by March 2021, mostly by shifting capacity from planned and elective procedures. Now, at the same time as increasing capacity, healthcare providers repurposed or redistributed capacity. In countries with private hospitals, these were used in the public system. And some countries use block booking of private sector capacity to have flexibility throughout the crisis. Sometimes private sector capacity was used for COVID-19 care, while other times it was for non-COVID-19 patients, such as in England. Another thing we observed was that countries transferred capacities between facilities, regions, and countries. And some even transferred patients from the hardest hit regions to areas with spare capacity, and sometimes even outside of the country. Throughout these changes, monitoring needs to be important of all of these different capacity updates. But many countries did not have the information they needed to have an overview and make decisions. Some countries use systems to oversee resource availability, such as in the Netherlands, which has a system that shows hospital bed availability. Another crucial thing to highlight is all of these capacity changes need to be coordinated with the health workforce. However, the plans to focus to increase infrastructure and workforce capacity were not always developed at the same time, which resulted in excess beds without skilled staff to operate them. And Gemma will focus on the health workforce later in our session. All of these points discussed on the slide also need to be seen in the context of the variation in the starting point, and countries with a high density of hospital and ICU beds, including Switzerland, Austria, and Germany, could use this extra capacity immediately to absorb the sudden demand for health services while having the time and flexibility to increase capacity over time. While this excess capacity may have been seen as inefficient before the pandemic, if it's really needed in an urgent way, it could be viewed as an asset. But at the same time, having excess capacity in hospitals doesn't mean that patients needed to be treated here, and patients could have been more effectively treated in the primary health care or outpatient settings in certain cases. Next slide, please. And this brings us back to the ways healthcare providers adapted or transformed service delivery. And we can revisit the question from the beginning of the presentation. How did health systems transform service delivery while still addressing other health needs and accommodating new needs for COVID-19? Partially, this builds on the capacity changes that were discussed before, because the novel use of physical space could be used to separate patients and create transition areas that allowed healthcare providers to more effectively care for the variety of patient needs. Hospitals could concentrate on severe COVID-19 patients in separate wards while maintaining COVID-19 free spaces for other urgent hospital treatment. This also highlights the exploding use of remote services across countries during COVID-19. Care provided over the phone or video enabled service providers to reach patients without a risk of infection, although this also has to be considered in the context of how this care is actually delivered. Another point to consider in delivering both COVID and non-COVID care is how to decide what services to maintain if healthcare providers become overwhelmed. The definition of essential services varies, but it often included urgent treatment, maternal services, chemotherapy, and dialysis, as well as some other things depending on the country context. While countries often defined what is defined as essential at the national level in consultation with medical professional groups, certain countries, particularly those who have a more decentralized health system, left decision-making to individual physicians. In addition, countries and healthcare professionals have had to find ways to rapidly disseminate information about both managing COVID-19 as well as how to safely treat non-COVID patients. And this brings us to primary healthcare, which is often the first contact point of patients to the healthcare system. At the beginning of the pandemic, a lot of attention was placed on hospitals and, for example, ensuring that personal protective equipment was available in the hospital setting. However, primary healthcare providers are also exposed to patients especially those who do not yet know if they have an infection. And these providers provide key health activities for public health, such as screening, testing, and more. For example, in San Marino, a response team composed of primary healthcare doctors, nurses, and social workers, as well as hospital specialists, worked together to visit patients at home and verify compliance with the rules for isolation or the need for hospitalizations. The role of primary healthcare cannot be understated, and it is something to bring forward beyond COVID-19. Next slide, please. So to wrap up with some final thoughts, the design of both the physical infrastructures as well as the design of patient care pathways could be more flexible to respond to future shocks. While part of this flexibility can be found in the private sector, and this was done during COVID-19, there may be many other ways to scale up and down capacities, even within the public sector. And in terms of the new models of care, they need to consider how they may influence the patient care experience, both from the patient perspective and the healthcare worker perspective. And when we're developing these new models of care, what mechanisms are required for them to make happen and to enable them to really function? Definitely the IT infrastructure is something that needs to be there, especially if we're continuing to do a lot of remote treatments, but also just the context of having quick doctor's appointments, there isn't the flexibility to have technical issues that can kind of happen when things are not face-to-face. The continuous delivery of services during COVID-19 also depends on things much outside of actually the service delivery environment. It depends on the effectiveness of the public health response, as well as the other health systems functions of health workforce, financing, and governance, and all of these have to work well. Without these elements, the ability to provide both COVID and non-COVID care is compromised. Next slide, please. So thank you again for attending our session, and if you're interested in learning more, there are several articles from colleagues in health policy and neurohealth, which in particular provide more country examples. And of course, keep on the lookout for the resilience study coming soon. Thank you very much. And over to Erica.
Thank you very much, Erin, for that fascinating overview. So when we talk about public health, I'm not going to actually go to into the tricky waters of defining it. But one of the striking things about it is that it is largely invisible. When everything is going well, everything that happens under the surface. It's like a swan going over a lake. So the public health teams are working away under the surface, and everything else enables everything else to smoothly glide ahead. And in this pandemic, I think it's become clear that the important role that public health plays for supporting the wider health system. So next slide, please. So public health in this pandemic has occupied a kind of dual role. It's faced unprecedented pressures from multiple demands. It's needed to design measures to reduce transmission of COVID and develop policies to counterbalance their unintended or undesirable consequences. Such as, for example, maintaining the delivery of essential public health services, such as screening programs and vaccination programs. The initial response was dominated, in the absence of a vaccine, by non-pharmaceutical interventions to control transmission. And these were supported with varying degrees of success with find, test, trace, isolate, and support services. Now that we have an effective or a range of effective COVID-19 vaccines, and those have been available since late 2020, public health systems have also needed to develop and implement mass vaccination campaigns. But as resources have shifted and access to services, routine services were constrained, it was very difficult to maintain, or it has been very difficult to maintain, other core public health functions alongside the pandemic response. Where public health efforts have been less successful, it's all patients that have suffered, because weaknesses in public health have led to health systems becoming overwhelmed by COVID cases and unable to provide their routine non-pandemic services. Next slide, please. So public health measures, the non-pharmaceutical interventions that were used to reduce transmission, have varied in their scope, but in all countries they've included some combination of hygiene measures, especially initially. The focus was very much on hand washing because that's so important for the control of influenza. But as we've learned more and more about SARS-CoV-2 as a virus, we've learned much more about the importance of respiratory hygiene and things like face coverings and the role that they have to play. Physical distancing has also been an important component, curtailing mass gatherings and restricting movement around the country. Now, national implementation of these different interventions has ultimately depended on the political priorities and weighing the public health benefits against perceived potential adverse effects on mental health or the economic and social impacts of these interventions. And deciding on which measures to implement, when to implement them and how to do so has been a really complex process that has required the ability to generate and update best practice to inform policy decisions in the context of uncertainty and changing evidence. And that's something to really emphasize. This is a new disease that we're still coming to terms with and we're still learning more about. So when all of these non-pharmaceutical interventions varied greatly. So in some countries, physical distancing was keeping 1 meter apart. In others, it was 1.5 meters. In others, it was 2 meters, or it was 6 feet, for example, in countries which still use imperial measurements. So there was this sort of variation across. And many of the interventions that supported physical distancing and things such as closing schools and mass gatherings often became colloquially labelled lockdowns. But a lockdown in one country was never the same as the lockdown in another country. So the severity of the lockdown, if you could measure these things, varied. Depending on the political decisions that were made. So most countries across Europe chose to restrict mass gatherings, for example, and that was often based on the number of attendees, but that also varied depending on whether it was an indoor event or an outdoor event. So, an indoor wedding might be allowed 20 people, whereas an outdoor wedding might be allowed 100, for example. The internal and external travel restrictions has been a big focus for more recently, as people have, or as countries have sought to introduce COVID passports to facilitate safer international travel, and as one measure to potentially reopen the economy, particularly in relation to tourism. But as we're finding, this is not necessarily producing the results that we were hoping for, and in a way adds an extra layer of complication that doesn't necessarily improve equity or outcomes. Okay, next slide, please. Let's go on to find, test, trace. So the implementation of find, test, trace, isolate and support systems services, it was much easier to do that in countries which already had stronger public health and stronger primary care systems with strong community linkages. There was quite a lot of use of digital technologies, including contact tracing or symptom tracking apps, and they were designed to support FTTIS activities in many countries, but these generally have actually not had the impact that people had hoped, the developers had hoped. They've had varying efficacy or effectiveness, and a lot of that has come down to the fact that people haven't been downloading them. So there's not necessarily, there's been issues around trust, which has meant that which has acted as a very strong barrier to the use of these sorts of digital technologies. And through the first year of the pandemic, it became increasingly clear that more traditional tracing methods that involved human beings and telephones were seemed to be much more effective. So I just have to turn off my camera for a second. I'm afraid I have a cold. Okay. So the other thing to bear in mind with this is that the find, test, trace, isolate, and support is a system that is a whole. Each element is, in a sense, equally important. You need to find your COVID cases, but once you've found them, you need to be able to test them. Once you've tested them, you need to be able to trace the contacts. And you also need to have systems in place to support isolation. Now, in some countries, isolation facilities were provided at no charge. In others, people had to pay for these services. And these particularly for people who are not able to isolate at home. But to be effective, support for isolation needs to go beyond just providing with people with alternative accommodation, because you have to ensure that people have the financial means to stay off work for the period of isolation without suffering further economic consequences, such as being made redundant or having to cope with a massive drop in income. Furthermore, it's clear that isolation support requires a dedicated workforce who can support those isolating. Now, in some countries, that came down to volunteers, and civil society organisations also played a very important role. Okay, so next slide, please. So as I said, we now have a range of vaccines available, and after a relatively slow start, EU member states have been able to manage the COVID-19 vaccine procurement reasonably well. And the sort of vaccine procurement done at the EU level has greatly facilitated access, particularly for smaller countries, because countries that are outside the EU have relied on bilateral negotiations, which is fine if you're a relatively big and wealthy country. But smaller countries with smaller populations don't necessarily have the same purchasing power. And it is, and they have faced more difficulties unless they've been included in the EU level procurement. The other option for countries, non-EU countries who don't have the bilateral negotiating power, has been to go through COVAX. But as we all know, COVAX has faced serious problems with supply and shortages. Now, as we can see from the diagram, there's lots of different elements to develop to a vaccination program in a pandemic setting, because you've got to look at the development of the vaccine, then you've got to think about how you're going to manufacture it, you've got to think about procuring it, authorizing it, storing it, distributing it, and that's just the sort of supply chain, and all of that is quite complex in and of itself. But just getting the supplies, that in a sense is just the first step. The next step is to actually do the vaccinations. So you've got the vaccine, and now you need to do the vaccinations. And all countries, because of the limited supply initially in Europe, went through a system of prioritization. Now, that most commonly the people prioritized were older age groups, particularly vulnerable groups, people with specific disabilities, for example, but also the healthcare workers, who are also more likely to be exposed. Once you've decided on your priority groups and you've found a way of actually picking them out of the rest of the population, you then have to decide where you're actually going to deliver the vaccines. So you're going to have these mass vaccination venues, often at sort of like football stadia and things like this. Are you going to have fixed sites in hospitals or in primary care? And this has been approached relatively flexible to facilitate a more rapid rollout. So initially, yes, the vaccination sites were in sort of fixed hospital or primary care settings. But as things have moved on and there has been a need to vaccinate more and more people, there's been a growth in things like mobile vaccination points, drop-in vaccination centres, things like this. And as I said, using football stadia, shopping malls, things like this as vaccination sites. It's also not the site as well. Gemma will talk a bit more about the role of the workforce in all of this, but the workforce is also key. It's not just about the where are you going to deliver the vaccines, it's who is going to deliver the vaccines. Most countries have relied on nursing staff or doctors to deliver vaccines, but there's also been a very strong role for lay vaccinators, pulling in people from the military and things like this, but also volunteer teams to support either to support the vaccination process by taking on a lot of the administrative burden, or actually delivering vaccines. Now, countries have been able to manage the logistical and procurement challenges relatively well, but even where systems for large-scale routine vaccinations already exist, they have been challenged by the unprecedented scale and speed of the COVID-19 vaccination process. And careful planning has been required so that the various elements all work together. Because the last thing that often gets forgotten is the monitoring. So you've got to make sure that the course is completed, where you need multiple doses. You have to monitor for adverse effects. You have to measure your coverage of the population to try and reach as many people as possible. And you also have to monitor the efficacy of the vaccine. And that's becoming increasingly important as we're seeing new variants emerge. Next slide, please.
Erica, can I just jump in to say
Yes,
you're slightly over time here?
Sorry.
So just 15 seconds to
skip the
wrap
next
it all
bit
up.
then. I'm going to wrap it up. Sorry.
Yeah, perhaps give us some key messages.
Yes, key messages. So if we jump to the last slide. So public health interventions matter, and pandemic surge capacity for public health should not be neglected in planning. Vaccines are wonderful, but the non-pharmaceutical interventions and find, test, trace, isolate support still matter. And without these elements, case numbers can still overwhelm the health system. COVID-19 has highlighted pre-existing public health challenges that need to be addressed between pandemics to strengthen the response, but particularly around vaccine hesitancy and socioeconomic inequalities. Thank you very much. And I'm sorry for overrunning.
Right. Thank you, Erica. I think you're an absolute champion for getting through that presentation when you're so sick today. Right. So we're going to move on now to look at the different strategies that countries have taken to mobilize and support their health workforce during the pandemic. Next slide, please. So, as we all know, the health workforce in each country has been at the forefront of health system responses to tackling COVID-19. But in order to launch an effective response, countries have had to take an enormous range of complex actions to rapidly scale up, redeploy, repurpose, and retrain their health workforce. And this has had to be done for a number of reasons. So countries have had to create surge capacity, firstly, to cope with a huge increase in demand from COVID-19 patients, in particular in acute and emergency care settings. At the same time, as we've seen from Era's presentation, countries have had to try and maintain essential services for non-COVID-19 patients. And while during the first, maybe the second wave, countries opted to stop routine services, more recently, we've seen countries try to keep routine services going try to also treat COVID-19 patients and also maintain essential services. And on top of that, they've had to try and catch up on all of the care that was missed in earlier waves when care was postponed. At the same time, the health workforce has been central to testing and monitoring and surveillance activities. And this year as well, they've been central to the vaccination programs, which has probably been the largest and most complex vaccination programs countries have ever done. So these actions are extremely complicated, and they've been made even more complicated by a few different factors, as some of these factors predated the crisis. So we see many countries in Europe actually entered the crisis with pre-existing workforce shortages. And you can see this graph on the right of the slide, with the exception of Germany and some of the Scandinavian countries. Most countries entered the crisis with a low number of doctors, a low number of nurses, or both. However, this masks sort of bigger challenges and issues with the workforce. So many countries had a maldistribution of workers. So, for instance, there may have been a shortage of workers, particularly in rural areas, perhaps in poorer areas. And there was also misalignment between skills in many countries. So the skills that were needed in the pandemic, perhaps countries didn't have enough ICU specialist doctors and nurses, didn't have enough paramedics, they didn't have a big enough public health workforce. And at the same time, the specific conditions of the pandemic also created other challenges. So there was workforce depletion because health workers themselves were getting infected with COVID-19, and they actually were probably more at risk than the general population, particularly in the first wave, or they were exposed to the infection and had to isolate and take time out of work. There's also a huge mental health burden because obviously the health workforce have been under a huge amount of stress and strain for 18 months now, and they've been caring for very sick and ill patients who've been dying. At the beginning, especially, we had very much uncertainty and little idea of how to treat patients effectively. And this has the risk of causing staff to burn out and perhaps need to take time away or to leave their profession altogether. Finally, there were many practical barriers to working. We've seen in Erica's presentations, obviously we've had lockdowns, we've had transport stopped, so that may have created barriers to getting to work. Schools were closed, so healthcare workers then had to look after their children unexpectedly. Some workers with relatives that were shielding had to go and live in other accommodation. So these all create practical barriers for them to get to work. And so in this presentation, I'm just going to hone in and talk about the areas highlighted in yellow on this slide. So look at how countries created surge capacity, the actions they took to protect the mental and physical health of health workers, and how they try to overcome some of the practical barriers to working. Next slide, please. So looking first at options to scale up surge capacity, and really these can be grouped into sort of two main areas. And on the first slide, I'll look at the first area, which is expanding existing workforce capacity. Then in the next slide, I'll look at actions taken to bring in new workers or bring back inactive workers. And the data here is from the HSRM, which Anna spoke about earlier. So we went through all the countries to sort of look at what all countries had done to create surge capacity. And we saw that almost all countries took actions to modify existing work practices. So this was in terms of getting staff to work extra hours, modifying work schedules, suspending rotations, suspending night shifts, cancelling leaves of absences, etc. And at the same time, most countries also took steps to reskill, redeploy and repurpose their workforce. So we saw that half of countries either reassigned health professionals to other specialties, to different roles, or expanded scopes of practice. And I've got some examples on the right of the screen. So in France, for instance, we can see pharmacists were authorised to issue e-prescriptions for patients with chronic diseases. In Belgium, non-nursing professionals could perform nursing tasks under supervision. In England, dentists, particularly those with sedation skills, were redeployed to hospitals. And in Austria, paramedics were authorised to administer vaccines. And these are just a few examples, and there are a huge range of examples from across the region. We also saw Sorry, if you could go back to the other slide. Sorry, thank you. So we also saw that 1/3 of countries redeployed health workers to regions or facilities with greater need. So Italy, for example, shifted workers from the south to the north in the first wave. And some countries such as the UK and Ireland brought private sector workers into the public sector. Next slide, please. And so with the other group of strategies to create surge capacity, countries brought in new or brought back inactive workers. And the most common strategy was to utilise final year medical nursing students and allow them to graduate early. Countries also brought back retired or otherwise inactive professionals, such as Ireland, for instance, launched their Be On Call for Ireland campaign. Countries such as Portugal launched exceptional procedures to recruit new health workers. Germany and the UK launched procedures to bring in foreign trained but unlicensed professionals through fast track procedures. We also had support from international workers. So you can see for Italy, for example, Romania, Norway sent physicians and nurses to go and work in Italy during the first wave. Next slide, please. And so moving away from surge capacity, we'll look at some of the strategies that countries took to try and protect the physical, mental health of health workers and provide practical support. And of course, these measures also help to maintain the capacity of the workforce. So in terms of physical support, countries had to ensure sufficient supply of PPE and regular testing of health workers, but especially in the early phase of the pandemic, that proved immensely challenging in many countries due to capacity constraints. Countries also moved vulnerable staff, perhaps due to age or having underlying chronic conditions, to work remotely. And of course, more recently, health workers in most countries have been prioritised to receive vaccinations. Mental health and wellbeing support has been a huge focus during the crisis. And this has been provided through helplines, websites, offering remote counselling sessions, mindfulness sessions, relaxing rules to access mental health support. And then I'll skip forward to other practical measures. These were sort of keeping schools open for essential workers, including health workers, offering free parking, free transport, free accommodation for health workers, and providing continuing medical education for people that took on new roles or new tasks. Next slide, please. And in a new paper that you can see the link to at the bottom, myself and co-authors sort of mapped all of the governance implications of taking these actions. And these are just some of them on the screen. But if you read the article, you'll see that there are a huge range of implications, and actors at all levels have had to work together and take actions to put in place all of these different elements. So from the national level, we needed national regional policies, we needed legislation, we needed regulation. Employers and managers have had to take on a huge range of tasks that they perhaps normally wouldn't do. Next slide, please. And so just really quickly to conclude, so we've seen huge range of actions by different actors at all levels. But thus far, we've got little information on how these strategies play out in practice. But it's really important that countries continue to evaluate these initiatives, because the learning can help inform strategies for surge planning and delivering effective crisis responses in the future. Not only that, it can also help to inform long-term health workforce reforms, because while some of these measures may be temporary, others such as the expanded scope of practice, new roles may be important for delivering and developing a more resilient workforce in the future. And finally, just one last important point. I think the long-term mental health support is going to be really important as we go forward, because these fixes that we've seen are just sort of really short-term and they're not going to be sufficient in the long term. So we need properly co-developed with health worker, mental health support strategies and investment in this area. And I'll leave it there. Over to you, Ruth.
Thank you. Can we have my first slide, please, Chiara? Thanks. So I'm gonna talk about what have we learned about financing COVID-19 services, but it's not only COVID-19 services. As Erin and Erica and Gemma told, there was this need to cover both services, the routine services and COVID services. I am Ruth Weitzberg. I'm a research fellow at the Department of Healthcare Management at the Technical University of Berlin. So can we start the presentation, please, Chiara? Why do we need to adjust financing anyway? So in order to cover and support all these changes and all these responses that were mentioned by all my colleagues until now. There was increased expenditure, so there was this sudden demand for COVID-related services that was unexpected by all countries. These are very high-cost services, more than sometimes routine services, because COVID patients have long hospital stays, they need isolation treatment, they need complex care in ICU units, and all countries had to increase significantly the investments to expand ICU and hospital capacity and workforce, as you heard from Jemaine 2 minutes ago. And also providers had to take on new tasks. So, for example, hospitals and community professionals, for example, general practitioners and specialists, they had to start testing patients, treating COVID patients. They did more home visits because patients could not come to the clinics, and provide more remote services because they wanted to protect the providers and the patients. And all of them had to face stricter hygiene requirements that cost money, keep greater physical distancing in the clinics, so they have to reshape clinics, and that costs money. And there was a greater use of personal protective equipment and testing equipment, and this all costs money. So the systems needed more money in general. And not only that, at the same time, the income that health system had was reduced. First, because the elective admissions were temporarily put on hold. So some providers saw a great reduce in their income because they weren't working, so the payments were coming to them. Patients also avoided seeking care at the beginning of the pandemic, and that also undermined the income of many professionals like specialists and hospitals. And at the greater scale, the taxes and contributions decreased due to the financial crisis and unemployment. And you can see in the graph here that the general government revenues fell in many countries in the first year of the pandemic. So on the one hand, we had greater expenditures and costs, and on the other hand, we had lower income and lower resources available for the system. So how did systems cope? Let's see if, in the next slide, please. First, countries had to ensure sufficient and stable funds to meet the needs. So countries used financial reserves when they had, for example, Germany, Estonia, and the Netherlands had general health systems with some reserves. They could use it, but most countries had to reallocate general government funds to the health system because there were none leftovers for the health system. But many countries also didn't have these funds to move to the health system. They had to borrow new money and raise additional funds, for example, through selling bonds or receiving financial assistance from the international lending, like the International Monetary Fund. And some countries also recurred to humanitarian aid coordinated with the European Commission, the UN, and the World Bank. And the European countries, they had access to the European Union's recovery funds for the member states that were granted mainly by grants and loans. But countries will have to go back to the counter-cyclical health financing to help ensure the stability of health financing and the resilience of the health system. Because if you spend so much now, you will have to save for the future. Otherwise, the health system will be drawn from the resources they have. Next slide, please. The second strategy was directing funds where they were most needed, and that meant mainly being more flexible on the way they procured and purchased resources. So, for example, countries had to skip tenders when they were buying testing kits and personal protective equipment. Some countries had to temporarily move to centralized purchase because that would be faster than each provider buying their own equipment. And new public and private partnerships were made because the private systems sometimes could support the public system with resources and workforce. So, for example, Cyprus, they expanded the workforce when patients could not be treated by public hospitals, they were moved to private hospitals and still funded by the Ministry of Health. And then they could increase the capacity without, great changes besides the funding. But still, this flexible procurement and private public partnership, they should comply with good governance practices to avoid negative unintended consequences. So, for example, they have to be very transparent to avoid corruption. And this is something that will have to be revisited after the pandemic is over. Can we move to the next one, please? So we were talking about compensating providers for income loss because they had this hold on elective care, and many providers didn't need any kind of adjustment in the payment because they are paid not based on the activity. For example, they are paid based on salaries or capitations. So the old payment is enough. But many providers that are paid based on activity had to have their payment adjusted. And that was done mainly by temporarily replacing activity-based payments with budgets or salaries that were set based on previous year's turnover. And that happened in hospitals, but also in outpatient clinics as well. Some countries also removed the P4P, payment for performance components of the payment to give more stability for providers. And also countries created new fee-for-service payments to incentivize providers to provide e-health, remote consultations and teleconsultations to avoid a greater loss of income, and also to catch up with the activity that was put on hold, and also to promote home visits because many people that live in nursing homes needed this type of service during the pandemic because it was too risky for them to leave their homes. Next slide, please. Providers also had to be compensated by the extra expenses that COVID posed on them. For example, these extra costs of PPEs, of sanitation, the reshaping of clinics. So countries created new payments to account for these extra costs. So hospitals, for example, received the new per diem payments for COVID-19 wards, or new DRG codes for COVID-19 patients, and new fee-for-service for COVID services that were new for the system. For example, triage of COVID patients, tracing, testing, vaccination. All of these services had to be reimbursed in a new way, and these payments were created very fast by countries to promote and incentivize providers to provide this kind of service. Also, the countries, they provide materials in kind, for example, equipment for testing and personal protective equipment. Other countries chose to reimburse the providers by this extra spending, but not providing in kind. Either way, the public sector covered this kind of costs. Next slide, please. So the last strategy that was implemented in most countries was increasing and supporting the coverage, universal health coverage. And this is very important because if people are not properly covered, they're not gonna seek for care that can have very negative consequences on their health and also on other people's health, because if sick people don't stay home and don't receive treatment, they can also spread more the virus. So countries expanded the coverage for non-residents that were not previously covered, for example, and they also reduced the financial barriers for seeking care. So they abolished co-payments, and they also included new services to the basket of services to cover all the services that were needed during the COVID crisis. And a good example of it is that For example, COVID tests and vaccinations were covered for the entire population, so the population that was covered was expanded, and these services were provided free of charge, so also the direct costs were reduced significantly. And the pandemic has re-emphasized the importance of universal health coverage, because otherwise it's not enough to have all the health force and the resources over there to treat people if they have financial access barriers and cannot come and receive the services. So I am wrapping up here. I'm gonna move to Anna, she's gonna talk about how all these strategies were put together in governance, and financing was just, you know, the baseline, the base to start governance from here. It's not enough to have financing if you don't have a good governance, right, Anna? So over to you.
Thank you very much, Ruth. With this introduction, we can move straight on to my first slide. Thank you, Chiara. So the COVID pandemic has clearly demonstrated that governance is essential for a resilient health system response to a shock, and especially a shock such as COVID-19 that affects all aspects of societal life. And although resilience can be bolstered by ensuring that health systems have adequate financial, physical, and human resources, we have seen that this is not enough, and resilience is not just a function of health systems' hard assets. Constructive deployment of these assets relies heavily on governance. And then indeed, as we all know, countries that were at the top of the Global Health Security Index in 2019, which is an index that focuses on measuring technical preparedness to epidemics and pandemics, were not among the best performance during the COVID crisis. So governance really is key, but what is governance and how can we assess it during COVID? So in simple terms, governance can be understood as the way decisions are made and implemented, but assessing it is in fact very complex. So let me unpack some of its facets. So governance enables the financing, resource generation, and service delivery functions to operate as they are intended, and in order to maximize their performance. So for example, governance of health workforce, as very briefly mentioned by Gemma, has been pivotal in redeploying and repurposing the workforce during pandemic. At the system level, governance enables the various functions to work in unison, for example, by ensuring there is a clearly articulated strategic vision to which governments can then be held to account, or by ensuring that best evidence drives decision and policy making. This is underpinned by state capacity, which requires things such as competent local and regional governments, administrative and bureaucratic institutions, professional health service, for example, to implement the necessary legislative and regulatory changes, as well as specialized services such as the police, for example, for ensuring compliance with measures. The governance function also goes beyond the health system through interaction with other sectors, as we have seen in the pandemic, such as education sector, and also increasingly is conducted across levels, from local to global levels, and with multi-level governance becoming increasingly important, as we have seen over the past months. New approaches to governance have also appeared over the course of the pandemic, with more actors such as private sector companies, NGOs, civil society groups, and many others providing support to governments in the responses. So all this makes governance very complex and evolving, and there's no single concept of health systems governance with a framework that is commonly accepted. So assessing governance, even in normal times, is therefore very difficult, and it is even harder in times of crisis. However, analyzing the country responses to the pandemic, as we were doing in our study, has allowed us to distill a list of key governance factors that supported and in some cases undermined a resilient health system response. Can I have the next slide, please? So these are these strategies, and I'm not going to describe them in much detail as there isn't enough time. But I'm going to highlight a few lessons that have emerged, focusing particularly on those where there were problems. So next slide, please. So the first problem was that we were not prepared for dealing with a virus like this one. Many mistakes have been made in responding to it, including a failure, as highlighted by Erica, to realize the importance of pre-symptomatic airborne transmission, and a failure to remember that previously SARS had been controlled by a policy of maximum suppression. Instead, most countries in Europe assumed that, as with pandemic influenza, for which many of them had plans, widespread community transmission was inevitable, and chose a different approach. But irrespective of this approach, deciding on a clear strategic direction was important, as it allowed stakeholders to make concrete plans for action, although this was not always set in stone and has been adapted or more radically changed as we have learned more about the virus. This was supported by drawing or quickly developing response plans and emergency legislation to give government special powers, but this of course had some risks as well. And even if the emergency plans that predated COVID had limited applicability, the process of planning itself that preceded development of these plans was still useful, because it forced those who participated in this process to interact with each other and better understand other perspectives, which they would normally not encounter. Another problem was with monitoring, surveillance, and early warning systems. These systems were crucial for early detection and ongoing management of the response. For example, they allow countries to develop effective and timely public health containment measures, strategies for healthcare delivery, and policy actions outside health, such as social support. But these systems had many weaknesses. So with exponential growth in cases, we really need accurate and timely data. And in many countries, existing surveillance and monitoring systems have been enhanced to inform pandemic response. Unfortunately, many countries had failed to invest in surveillance systems in the past, and some had to set up systems from scratch with limited infrastructure and expertise, such as limited expertise in sequencing to track evolution of new variants. So there are many other weaknesses in surveillance systems. For example, more than a year into pandemic, many countries were unable to supply data in a comparable format. Some used different definitions or collected data in different ways. Another problem was that most information was supplied in aggregate form. This resulted in many disadvantaged groups, such as ethnic minorities or others, becoming invisible in most countries, and then invisible in the policies. Other weaknesses include the lack of One Health approach in most countries, and weaknesses in national, EU level, and multilateral early warning systems. I'm going to move on to, sorry, please, can we go back? Just skipping a few of the messages to save time. Another problem area worth highlighting is that in many, that was a problem in many countries, is that political decision-making and implementation did not always safeguard transparency, legitimacy, and accountability. And the speed with which decision-making had to be made did not always allow sufficient scrutiny. And this is always problematic and should always be avoided, as already highlighted by my colleague Ruth. A lack of transparency can create conditions for mistakes, or worse, for corruption. And while many good practice and then undermine trust. And while many good practice examples can be found, there are sadly also many examples when decisions were made that benefited others than those who are in need, and eroded trust in their response. Another observation is that despite the crucial need for effective communication that is coordinated across channels and actors, this has often been a neglected area during the COVID response, with national communication strategies lacking in many countries. What's more, targeted communication to address specific groups, such as people who don't speak the official country's language, was generally also underutilized. And of course, it is not just public health authorities who can disseminate information, but also those whose intentions are to spread misinformation or even deceive. And the pandemic has provided an opportunity for some individuals and organizations to do so. The WHO and the EC have played a key role in combating misinformation, but in most countries, further national efforts have also been necessary. Another observation is that non-governmental stakeholder involvement could also be improved or could have been better. Many countries, although not all, have vibrant civil society organizations, and many of these organizations have played important roles in the pandemic. For example, in delivering services to vulnerable groups, or as a source of information about how the pandemic is affecting ordinary people. And policies are more likely to work if they are developed in partnership with those who must implement them and who understand far better what is possible than anyone in the ministry can ever know. In these ways, stakeholder participation is a really invaluable resource, but unfortunately, in many countries, inclusion of civil society and community groups has been limited during this pandemic. A final observation I'm going to talk about, just mindful of time, is that international coordination of the COVID response has been fragmented with a lack of effective enforcement mechanisms. And this is despite long-standing cooperation in the area of communicable diseases control. Still, the WHO played an important role in drawing attention to various issues and coordinating global efforts. The EU has also played an important role and within a relatively short period of time managed to organize a broad range of support measures from coordinating repatriation of stranded citizens to vaccine deployment strategy and supporting post-pandemic recovery, and with many things in between. And in Southeast Asia, regional cooperation through the ASEAN Association has supported countries in containing the pandemic early on. So that's an example of international collaborative efforts. And the region's previous experience with pandemics such as SARS and MERS has given this organization an advantage. So many lessons are now being learned about how to move forward, and proposals have been developed to reform global health governance, but it will be essential that these proposals are followed through to achieve a long-lasting impact. So next slide, please. Yeah, so the final issue that I wanted to highlight is the critical role of political leadership in setting and implementing the pandemic response. And unfortunately, there were examples of particularly bad leadership over the past months. So what are good leaders? Risk analysis and disaster research literature identifies several key characteristics of leadership styles that promote resilience during and outside of crisis. These are responsiveness, resourcefulness, and capacity to learn. And some countries will have leadership with such capacities, but some will not. And the challenge is how those seeking to protect health can be most effective with leaders they have. So very quickly, political context will play a very critical role here, because it influences both the ability to act and the accountability of leadership. And this is, of course, not something that health systems can influence, but it's important to be mindful of it and act appropriately. Clever use of the data can help keep leaders to account. So numbers of COVID cases and deaths can be tracked in almost real time, which makes it possible for politicians to be held to account for their ability or inability to protect health. And this may motivate them to try to be better leaders, although as we have seen in the past, this has not always worked. And finally, strong governance that enables good health policy can also provide a defense against particularly bad leaders, because it determines the extent to what is possible for the politicians. For example, parliamentary and judiciary scrutiny and oversight can help ensure legitimacy of executive actions and accountability of political leaders. And these issues go beyond the realm of the health systems, but they should be better understood in preparation for future crises. Next slide. I think that is the final slide in which we do a little bit of advertising, and we have this brings us to the end of our sessions. We have about 4 minutes left for discussion. So perhaps, Chiara, we could have all my colleagues here on screen. I can't see any comments in the chat. It's perhaps a bit too early for questions for most people, but perhaps my colleagues could just say what they think about, based on the learning from the pandemic so far, relating to what they discussed in their presentation. What does this learning mean in terms of preparing for future health threats going beyond COVID-19? If there's any volunteers.
I suppose the buzzword for me would be valuing public health, investing in public health, but also ensuring that the systems you have in place have flexibility to adapt, because we know roughly when the next pandemics will be, where it will be coming from, but diseases are all different, so we need to be prepared.
Yeah, I totally agree with Erica, and I would also say that there's a lot of health challenges, the longer term ones that may not be in the news day to day, but are very severe threats to the health system. Antimicrobial resistance, for example, and the more flexibility you have to tackle various types of threats and not just infectious disease threats will help for health systems resilience.
Yeah. No, Gemma, go on.
Sure. Thank you, Ruth. So, I think for me, it's sort of, there are really long-standing issues with health workforce in most countries across Europe. So either not the right skills that they might need to meet sort of population aging, increase in chronic diseases, or not enough, workforce in terms of numbers. And I think we've known this. We didn't need a pandemic to sort of highlight those issues. So it's really important going forward that people really invest in the health workforce, get the right skills, get the right numbers, not just in preparation for a pandemic that might come along, but just for everyday needs. And to, now it's a really critical period to try and catch up on sort of care that has been missed, and sort of really invest in health workers themselves, support them, pay them properly, look after their mental health.
Yeah, and I would add that it's true that we need this flexibility to raise new funds through support health resources, workforce, public health, but there is a delicate balance between this flexibility and best practices and good governance that we have to revisit after this emergency or the main part of the crisis is over. We have to rethink and see how to reorganize these extra efforts for the long term. So, for example, if we spend too much money during the pandemic, we have to think about how to raise enough funds and how to reorganize these expenditures to maintain the health system sustainable for the long term, for example. So it's a matter of balancing the urgent needs, the long-term needs, the urgent needs of health professionals and the long-term needs of their mental health and well-being. It's a game all the time.
Thank you, Rose. So just to conclude and to echo our only comment we have in the chat, this pandemic has really shown light on the really long-standing and well-known problems across all the health system functions. And now really it is time to be serious about addressing them going forward. So thank you very much to my colleagues for presenting the session, and to everybody who attended this morning. We hope you enjoyed, and we hope you go back to look at some of our publications presented in this session. Thank you very much.
Thank you.